Anatomy, histology, embryology, and developmental anomalies of the esophagus. Ryan D. Modenick, Vishal Kaila 43. Anatomy and histology. The esophagus acts as a conduit for the transport of food from the oral cavity to the stomach. To carry out this task safely and effectively, the esophagus is constructed as an 18 to 26 cm long hollow muscular tube with an inner skin-like lining of stratified squamous epithelium, Fig. 43.1. Between swallows the esophagus is collapsed, but the lumen distends up to 2 cm anteroposteriorly and 3 cm laterally to accommodate a swallowed bolus. Structurally, the esophageal wall is composed of 4 layers: innermost mucosa, submucosa, muscularis propria, and outermost adventitia. Unlike the remainder of the GI tract, the esophagus has no serosa. 1,2 These layers are depicted anatomically and as viewed by EUS in Fig. 43.2. Musculature. The muscularis propria is responsible for carrying out the organ's motor function. The upper 5% to 33% is composed exclusively of skeletal muscle, and the distal 50% is composed of smooth muscle. In between is a mixture of both types. 3 Proximally, the esophagus begins where the inferior pharyngeal constrictor merges with the cricopharyngeus, an area of skeletal muscle known functionally as the upper esophageal sphincter, UES, Fig. 43.3a. The UES is contracted at rest and, hence, creates a high-pressure zone that prevents inspired air from entering the esophagus. Below the UES, the esophageal wall is composed of inner circular and outer longitudinal layers of muscle, see Fig. 43.2a. The esophageal body lies within the posterior mediastinum behind the trachea and left mainstem bronchus and swings leftward to pass behind the heart and in front of the aorta. 1 At the T10 vertebral level, the esophageal body leaves the thorax through a hiatus located within the right cruce of the diaphragm, see Fig. 43.1. Within the diaphragmatic hiatus, the esophageal body ends in a 2 to 4 cm length of asymmetrically thickened circular smooth muscle known as the lower esophageal sphincter, LE, see Fig. 43.3b. 4 The phrenoesophageal ligament, which originates from the diaphragm's transversalis fascia and inserts on the lower esophagus, contributes to fixation of the LES within the diaphragmatic hiatus. This positioning is beneficial because it enables diaphragmatic contractions to assist the LES in maintenance of a high-pressure zone during exercise. The LES is contracted at rest, creating a high-pressure zone that prevents gastric contents from entering the esophagus. During swallowing, the LES relaxes to permit the swallowed bolus to be pushed by peristalsis from the esophagus into the stomach. Innervation. The esophageal wall is innervated by parasympathetic and sympathetic nerves. The parasympathetics regulate peristalsis through the vagus nerve, Fig. 43.4. The cell bodies of the vagus nerve originate in the medulla. Those located within the nucleus ambiguous control skeletal muscle, and those located within the dorsal motor nucleus control smooth muscle. Medullary vagal postganglionic efferent nerves terminate directly on the motor end plate of skeletal muscle in the upper esophagus, whereas vagal preganglionic efferent nerves heading to smooth muscle in the distal esophagus terminate on neurons within Auerbach, myenteric, plexus, located between the circular and longitudinal muscle layers. 3 A second neuronal sensory network, Meissner plexus, located within the submucosa, is the site of afferent impulses within the esophageal wall. These are transmitted to the central nervous system through vagal parasympathetic and thoracic sympathetic nerves. Sensory signals transmitted via vagal afferent pathways travel to the nucleus tractus solitarius within the central nervous system, see Fig. 43.4, from there nerves pass to the nucleus ambiguous and dorsal motor nucleus of the vagus nerve, where their signals may influence motor function. 5 Pain sensation arising from the esophagus is typically triggered by stimulation of chemoreceptors in the esophageal mucosa or submucosa and/or mechanoreceptors in the esophageal musculature. 6 Central perception then occurs when these impulses are transmitted to the brain by sympathetic and vagal afferents. Sympathetic afferents travel through the dorsal root ganglia to the dorsal horn of the spinal cord, and vagal afferents travel through the nodos ganglia to the nucleus tractus solitarius in the medulla. Information from sympathetic/spinal afferents then proceeds via the spinothalamic and spinoreticular pathways to the thalamus and reticular nuclei before transmission to the somatosensory cortex for pain perception and limbic system for pain modulation. Information from vagal afferents in the medulla also travels to the limbic system and frontal cortex for pain modulation. Furthermore, because the esophageal neuroanatomic pathways overlap with those of the heart and respiratory system, in clinical practice it may be difficult to discern the organ of origin for some chest pain syndromes. 6 Circulation. The arterial and venous blood supply to the esophagus is segmental. The upper esophagus is supplied by branches of the superior and inferior thyroid arteries, the mid-esophagus by branches of the bronchial and right intercostal arteries and descending aorta, and the distal esophagus by branches of the left gastric, left inferior phrenic, and splenic arteries. 1-3 These vessels anastomose to create a dense network within the submucosa that probably accounts for the rarity of esophageal infarction. The venous drainage of the upper esophagus is through the superior vena cava, the mid-esophagus through the ezygous veins, and the distal esophagus through the portal vein by means of the left and short gastric veins. The submucosal venous anastomotic network of the distal esophagus is important because it is where esophageal varices emerge in patients with portal hypertension. 1-3 The lymphatic system of the esophagus is also segmental. The upper esophagus drains to the deep cervical nodes, the mid-esophagus to the mediastinal nodes, and the distal esophagus to the celiac and gastric nodes. However, these lymphatic systems are also interconnected by numerous channels, accounting for the spread of most esophageal cancers beyond the region at the time of their discovery. Mucosa. During endoscopic evaluation, the normal esophageal mucosa appears smooth and pink. The normal esophagogastric junction appears as an irregular white Z-line, ora serrata, demarcating the interface between the lighter esophageal and the redder gastric mucosa. Histologically, the esophageal mucosa is a non-keratinized, stratified squamous epithelium, Fig. 43.5. This cervical esophagus distance from incisors, thoracic esophagus, abdominal esophagus, trachea, aorta, right crus of diaphragm, lay UES 40 cm. Fig. 43.1 Anatomy of the esophagus and its relationship to adjacent structure. The esophagus, approximately 25 cm in length, originates in the neck at the level of the cricoid cartilage, passes through the chest, and ends after passage through the hiatus in the right crus of the diaphragm by joining the stomach below. On barium esophagogram, adjacent structures may indent the esophageal wall, including the aortic arch, left mainstem bronchus, left atrium, and diaphragm. Lay, lower esophageal sphincter, UES, upper esophageal sphincter. Modified from Lieberman-Meffert D. Anatomy, Embryology, and Histology. In Pearson F.G., Cooper J.D., Deloriers J., E.T.L., Editors. Esophageal Surgery. 2nd ed. Philadelphia, Churchill Livingstone, 2002. p. 8. Longitudinal folds, stratified squamous epithelium, lamina propria muscularis, mucosae, mucosa, submucosa adventitia, submucosal gland with duct, inner circular layer, outer longitudinal layer, muscularis a propria. B. Fig. 43.2 Cross-sectional and EUS anatomy of the esophagus. A. The anatomic layers within the wall of the esophagus are depicted. B. An EUS image depicting the pattern of light and dark rings created by echoes from the different layers. A. Interface between lumen and mucosa. B. Mucosa. C. Submucosa. D. Muscularis propria. E. Adventitia. Note that A, C, and E are hyperechoic, and B and D are hypoechoic. A. Modified from Nutra Mr. Pedicula Ha. The GI tract. In Weiss L., Editor. Histology, Cell and Tissue Biology. 5th ed. New York, Elsevier Science, 1983. p. 664. Chapter 43 Anatomy, Histology, Embryology, and Developmental Anomalies of the Esophagus 629. 43 Multilayered epithelium consists of 3 functionally distinct layers, stratum corneum, stratum spinaceum, and stratum germinativum. The most lumen-oriented stratum corneum acts as a permeability barrier between luminal content and blood by having layers of pancake-shaped glycogen-rich cells connected laterally to each other by tight junctions and zonula adherens and having their intercellular spaces filled with a dense matrix of glycoconjugate material. 7 The middle layer of stratum spinaceum contains metabolically active cells with a spiny shape. The spiny shape is due to the numerous desmosomes connecting cells throughout the layer. Furthermore, this same desmosomal network maintains the structural integrity of the tissue. The basal layers of stratum germinativum contain cuboidal cells that occupy 10% to 15% of the epithelium's thickness and are uniquely capable of replication. 2 Basal cell hyperplasia, defined as basal cells occupying more than 15% of epithelial thickness, reflects an increased rate of tissue repair, as is often seen in GERD. See Chapter 46. 2 The esophageal epithelium contains a small number of other cell types including argyrophilic neuroendocrine cells, melanocytes, lymphocytes, Langerhans cells, macrophages, and eosinophils. Neutrophils are not present in healthy epithelium. 2 Below the epithelium is the lamina propria, a loose network of connective tissue within which are blood vessels and scattered lymphocytes, macrophages, and plasma cells. See Fig. 43.5. The lamina propria protrudes at intervals into the epithelium to form reedy pegs or dermal papillae. Normally these protrude to less than 50% of the epithelium's thickness. When greater, it also is a recognized marker of GERD. 8 The muscularis mucosae is a thin layer of smooth muscle that separates the lamina propria above from the submucosa. Its functions are unclear. Submucosa The submucosa comprises a dense network of connective tissue, within which are blood vessels, lymphatic channels, neurons of Meissner plexus, and esophageal glands. See Fig. 43.2a. These glands, which vary as to number and distribution along the esophagus, consist of cuboidal cells organized as acini. 9 They produce and secrete a lubricant, mucus, and factors such as bicarbonate and epidermal growth factor that are important for epithelial defense and repair. The secretions from these glands pass into tortuous collecting ducts that deliver them to the esophageal lumen. Embryology. A brief review of the embryology of the upper digestive system is presented as a guide to understand the origin of many of the developmental anomalies discussed in this chapter. In the developing fetus, the oropharynx and esophageal components of the GI tract and the larynx, trachea, bronchi, and lungs of the respiratory tract develop from a common tube. 3 By gestational week 4, this tube, composed of endoderm, develops a diverticulum on its ventral surface that is destined to become the epithelium and glands of the respiratory tract. Fig. 43.6a to d. This diverticulum subsequently elongates, becomes enveloped by splanchnic mesenchyme, future cartilage, connective tissue, and smooth muscle, and buds off to become the primitive respiratory tract. Concomitantly, the lumen of the dorsal tube, the primitive foregut, fills with proliferating, ciliated columnar epithelium. By week 10, vacuoles appear and subsequently coalesce within the primitive foregut to re-establish the lumen. By week 16, the columnar epithelium lining the primitive foregut and future esophagus is replaced by stratified squamous epithelium, a process that is complete by birth. Developmental anomalies. Congenital anomalies of the esophagus are relatively common and are due to either transmission of genetic defects or intrauterine stress that impedes fetal maturation. Esophageal anomalies are common in premature infants, and 60% have other anomalies, reflected by the term vacteral, formerly fata, a mnemonic for the association of anomalies of the vertebral, anal, cardiac, tracheal, esophageal, renal, and limb systems. Common specific defects include patent ductus arteriosus, cardiac septal defects, and imperforate anus. 10 Esophageal atresia and tracheesophageal fistula. Esophageal atresia, a loss of continuity between the upper and lower esophagus, and tracheesophageal fistulas, abnormal connections between the trachea and esophagus, are the most common developmental anomalies of the esophagus. Figs 43.7 and 43.8. The incidence of esophageal atresia and tracheoesophageal fistula is approximately 1 in 4,000.11. The former results from failure of the primitive foregut to recanalize and the latter from failure of the lung bud to separate completely from the foregut. Inferior constrictor thyroid cartilage cricopharyngeus uesab less trachea proximal esophagus pleura a ring phrenoesophageal ligament sling fibers diaphragm squamocolumnar junction peritoneum fig 43.3a anatomic detail of the UES and its relationship to adjacent structures. B. Anatomic detail of the LES and its relationship to the diaphragm, phrenoesophageal ligament, and squamocolumnar junction. A. Modified from AGA Clinical Teaching Project. Esophageal disorders, upper esophageal sphincter anatomy, Slide 14, American Gastroenterological Association, 1995, B. Modified from Kerr-RM hiatal hernia and mucosal prolapse. In, Castel Du, editor. The Esophagus. Boston, Little, Brown and Company, 1992. p. 763. 630 Part V. Esophagus. Although the mechanisms are unclear, esophageal atresia and tracheoesophageal fistulas may result from genetic defects. Table 43.1.12 Proper sonic hedgehog signaling is one of the pathways critical to achieve separation of the respiratory tract from the primitive foregut. 13 Experimental administration of the anti-cancer drug, adriamycin, doxorubicin, into mouse or rat embryos. Fig. 43.4 Neural pathways of the esophagus. Extrinsic innervation is provided principally by the vagus nerve. Afferent vagal pathways carry stimuli to the nucleus solitarius, and efferent pathways originating in the dorsal vagal nucleus mediate esophageal peristalsis and lay relaxation. ACH, acetylcholine, NO, nitric oxide, VIP, vasoactive intestinal peptide. From Mittal RK, Balaban DH. The esophagogastric junction. N. English J. Med 1997, 336:924. Cortical stimuli pharynx esophagus crural diaphragm lower esophageal sphincter myenteric plexus and ACH VIP no phrenic nerve vagus nerve phrenic nucleus medulla inspiratory center nucleus ambiguous dorsal vagal nucleus solitarius motor pathways sensory pathways. Fig. 43.5 Esophageal epithelium. The human esophagus as shown on this biopsy specimen is lined by non-keratinized stratified squamous epithelium. The cells of the surface, top, are long and flat and have a small nucleus to cytoplasm ratio that contrasts with the cells of the basal layer, bottom, the density, cuboidal shape, and large nucleus to cytoplasm ratio of which account for their prominence. A subpopulation of these basal layer cells appears to have properties of esophageal stem cells. 7 Reedy pegs, or dermal papillae containing elements of the lamina propria, normally extend into the epithelium about 1/2 the distance to the lumen. Courtesy Pamela Jensen, MD, Dallas, TX. Primitive common upper digestive and respiratory tract ACDB lung bud foregut tracheoesophageal septum trachea bronchial bud lung esophagus stomach. Fig. 43.6 Developmental stages in the formation of separate respiratory and digestive systems. These systems are derived from a common tube of endoderm during embryogenesis. A. Single primitive tube. B. Formation of a lung bud in the 4th week. C. Elongation of the dorsal tube, primitive foregut, and lung bud and formation of a tracheoesophageal septum by 4 to 6 weeks. D. Separation of the primitive foregut from the tracheobronchial tree at 6 weeks. Chapter 43 Anatomy, Histology, Embryology, and Developmental Anomalies of the Esophagus. 631-43 commonly results in esophageal atresia and tracheoesophageal fistulas, as well as other anomalies that comprise the vacteral group, by altering sonic hedgehog signaling. 14,15 Esophageal atresia occurs as an isolated anomaly in only 7% of cases, the rest are accompanied by a form of tracheoesophageal fistula, most often, 89%, a distal type fistula, see Fig. 43.7b, and rarely, 3%, the H type fistula, see Fig. 43.7c, 43.16 in isolated atresia, the upper esophagus ends in a blind pouch and the lower esophagus connects to the stomach, see Fig 43.7a. The condition is suspected prenatally by the development of polyhydramnios, due to the inability of the fetus to swallow and so absorb amniotic fluid, and an absent or small stomach bubble. 17 The finding of a dilated proximal esophagus with a blind ending, also known as an esophageal pouch, during a prenatal US has high specificity for esophageal atresia, although the sensitivity of this finding is limited. 18 A distended fetal hypopharynx during US or MRI is an additional prenatal sign of esophageal atresia and has better sensitivity than an esophageal pouch. Prenatal MRI provides images of the entire length of the esophagus and can be used to assist in the diagnosis of esophageal atresia. 19 Additionally, visualization of a lower esophageal lumen during prenatal MRI suggests the presence of ABCDE. Fig 43.7 Esophageal atresia, A, and tracheoesophageal fistulas TEF. In the most common TEF, the trachea communicates with the distal segment of the atretic esophagus, B. The next most common type is the H-type TEF, in which the trachea communicates with an otherwise normal esophagus, C. A TEF in which the trachea communicates with both upper and lower segments of an atretic esophagus, D, or only with the upper segment of an atretic esophagus, E, is rare. Modified from the non-neoplastic esophagus. In Fenoglio Pricer CM, Editor. GI Pathology. An Atlas and Text. 2nd ed. Philadelphia, Lippincott Raven, 1999. p. 31. Fig 43.8 Chest radiograph depicting tracheoesophageal fistula. A catheter is shown coiled in the esophagus, arrow, at the level of the second thoracic vertebra with air in the stomach. From Foro Zapata L., Papagallo M. Esophageal atresia and tracheoesophageal fistula. N. English J. Med 2018, 379, 7E11. Table 43.1 Syndromic causes and distinguishing clinical features of tracheoesophageal fistula and esophageal atresia syndrome. Gene clinical features: anophthalmia, esophageal genital syndrome, SOX2, anophthalmia/microphthalmia, EA/TEF, urogenital anomalies, charge syndrome, CHD7, coloboma of the eye, cardiac anomalies, choanal atresia, intellectual disability, growth retardation, genital anomalies, ear anomalies, hearing loss, EA/TEF, Feingold syndrome, MYCN, esophageal/duodenal atresias. Microcephaly, learning disabilities, syndactyly, cardiac defects, Fanconi anemia greater than 20 genes, bone marrow failure, malignancies, short stature, abnormal skin pigmentation, radial ray defects, eye anomalies, renal anomalies, cardiac defects, abnormal ears, central nervous system anomalies, hearing loss, developmental delay, gastrointestinal anomalies including EA/TEF, VACTERLH, Fangseeb, vertebral anomalies, anal atresia, cardiac malformations, TEF, renal anomalies, limb anomalies, hydrocephalus, EA. Esophageal atresia, TEF, tracheoesophageal fistula. Adapted from Scott de Esophageal atresia/tracheoesophageal fistula overview. In Adam MP, Ardinger HH, Pagon RA, ETAL, editors. Gene Reviews Registered Trademark Internet. Seattle, University of Washington, Seattle, 1993. 632 Part V. Esophagus, tracheoesophageal fistula, Fig 43.9. At birth, the combination of regurgitation of saliva and a scaphoid, gasless, abdomen strongly suggests isolated atresia without a distal tracheoesophageal fistula because no pathway exists for inspired or swallowed air to enter the bowel. At the first feeding, the high complete GI obstruction of esophageal atresia results in the rapid onset of choking, coughing, and regurgitation, Table 43.2. Once suspected, the diagnosis can be confirmed by failure to pass an NG tube into the stomach and by a concurrent chest radiograph with air contrast in the upper esophageal segment, the air being introduced through a catheter positioned within the upper esophageal segment. In some instances, injection of 1 ml of water-soluble contrast into the obstructed segment helps with the diagnosis. Tracheoesophageal fistula usually accompanies esophageal atresia. The most common type of tracheoesophageal fistula is the distal type associated with esophageal atresia, see Fig. 43.7b, point 16. In this type, the atretic upper esophagus ends in a blind pouch and the trachea communicates with the distal esophageal segment. The clinical presentation with this configuration is usually similar to isolated esophageal atresia, with the additional risk of aspiration pneumonia from refluxed gastric contents entering the trachea through the fistula, see Table 43.2. Nonetheless, distinction between an isolated atresia and one associated with a distal tracheoesophageal fistula is straightforward because the communication between the trachea and the esophagus results in a gas-filled abdomen, as shown on plain radiographs, see Fig. 43.8. In some instances, confirmation of the type of configuration is obtained by esophagography with or without bronchoscopy. The three less common types of tracheoesophageal fistula occur when 1. The atretic upper esophagus communicates with the trachea, 2. Both upper and lower segments of the atretic esophagus communicate with the trachea, and 3. An H-type fistula communicates with the trachea in a non-atretic esophagus, see Figs 43.7e, d, and c, respectively. Because these types have in common the communication between upper esophagus and trachea, they all manifest clinically with signs and symptoms of recurrent aspiration pneumonia, see Table 43.2. Distinguishing among types, however, should not be difficult. Esophageal atresia accompanied by proximal tracheoesophageal fistula presents in infancy as recurrent pneumonia, and the presence or absence of bowel gas on a plain radiograph indicates whether an accompanying distal tracheoesophageal fistula exists. In contrast, in those with an H-type tracheoesophageal fistula without esophageal atresia, the diagnosis can be delayed until childhood or, at times, adulthood. Diagnosis of a suspected H-type fistula is usually made by esophagography, but this may be difficult owing to the small size of some communications. 20 In such cases, detection Fig. 43.9 esophageal atresia seen in a sagittal T2 weighted MRI sequence showing the proximal blind pouch, arrow, and the long distal esophagus, arrowhead. From Cassard M fetal body imaging, when is MRI indicated? J. Belg SOC Radiol. 2017, 101, S13. Table 43.2 Clinical aspects of esophageal developmental anomalies. Anomaly: age at presentation, predominant symptoms, diagnosis, treatment, isolated atresia, newborns, regurgitation of feedings, aspiration, esophagogram * plain film, gasless abdomen, surgery, atresia and distal TEF, newborns, regurgitation of feedings, aspiration, esophagogram * plain film, gas-filled abdomen, surgery, H-type TEF, infants to adults, recurrent pneumonia, bronchiectasis, esophagogram * bronchoscopy, surgery, esophageal stenosis, infants to adults, dysphagia, food impaction, esophagogram * endoscopy, dilation, surgery, esophageal duplication, cyst, infants to adults, dyspnea, stridor, cough, infants, dysphagia, chest pain, adults, EUS * MRI/CT, surgery, vascular anomaly, infants to adults, dyspnea, stridor, cough, infants, dysphagia, adults, esophagogram * angiography, MRI/CT/EUS, dietary modification, surgery, esophageal ring, children to adults, dysphagia, esophagogram * endoscopy, dilation, endoscopic incision, esophageal web, children to adults, dysphagia, esophagogram * endoscopy, Bouginage * diagnostic test of choice. Confirmatory test. Primary therapeutic approach. Secondary therapeutic approach. TEF, tracheoesophageal fistula. Chapter 43 Anatomy, Histology, Embryology, and Developmental Anomalies of the Esophagus. 633-43 may be improved by ingestion of methylene blue and searching by bronchoscopy for the blue-stained fistula site. Treatment of esophageal atresia and tracheoesophageal fistulas is surgical. Patients should be evaluated preoperatively for other vectoral anomalies, particularly for cardiac abnormalities. 21 The choice of surgical procedure depends on the distance between the upper and lower esophageal segments. Short gaps, gaps of fewer than 3 vertebral bodies, permit end-to-end anastomosis, as do some long gaps after lengthening of the upper segment by either bouginage or intraoperative myotomy. 16 Magnetic compression anastomosis, or magnamoses, has been used in the repair of some patients with esophageal atresia. 22 If approximation of the two segments is not possible, primary reconstruction is undertaken. The colon can be interposed between the proximal esophageal remnant and the stomach, or the stomach can be pulled proximal and anastomosed to the esophageal remnant. The results of surgical correction of esophageal atresia are excellent when it exists as an isolated anomaly, with overall outcome determined principally by the severity of concomitant cardiac anomalies and by the birth weight of the infant. 23,24 Survival after successful repair of isolated esophageal atresia has steadily increased over the years and now approaches 100% in the absence of other major malformations. 25 Despite dramatically improved survival rates over the last several decades, long-term complications are still common. In long-term follow-up, gastroesophageal reflux without esophagitis develops in 57% of patients. 26 GERD with esophagitis occurs in 40% of patients, with a 6.4% prevalence of Barrett esophagus. 27 The development of GERD is likely related to abnormalities of esophageal motility and impaired acid clearance following surgical repair. 28 Approximately 20% to 35% of patients will require fundoplication for GERD at some point during their lives. Unfortunately, 20% to 30% of fundoplication procedures in these patients will fail. 29 Dysphagia occurs in 50% patients who survive to adulthood. 26 Anastomotic strictures can be found in 30% to 56% of patients. Although several cases of esophageal cancer, both adenocarcinoma and squamous cell carcinoma, have been reported in adults who have undergone repair of esophageal atresia, registry studies from Finland and Sweden do not necessarily show a statistically significant increased cancer risk in these patients. 28,30 Congenital esophageal stenosis. Esophageal stenosis is a rare anomaly, occurring in only 1 in every 25,000 to 50,000 live births. 31 The stenotic segment varies from 2 to 20 cm in length and is usually located within the middle or lower third of the esophagus, Fig. 43.10a. The precise cause of the congenital stenosis is not entirely clear. Some patients, 17% to 33%, have other associated anomalies, the most common being esophageal atresia, see Fig. 43.10b, and tracheoesophageal fistula. 32 Three types of stenosis are recognized, based on histology. 1. Ectopic tracheobronchial remnants, TBRs, which are sequestered respiratory tissue, hyaline cartilage, respiratory epithelium, suggesting its origin is incomplete separation of lung bud from primitive foregut. 33. 2. Fibromuscular hypertrophy, associated with damage to the myenteric plexus with loss of the muscle-relaxing nitrinergic neural elements, and 3. Membranous diaphragm, which is limited to the mucosa and does not involve the muscle layers. 34 A systematic review showed that congenital esophageal stenosis secondary to fibromuscular hypertrophy makes up 54% of cases, 30% of cases occur secondary to TBRs and 16% are secondary to membranous diaphragms. 35 Membranous diaphragms are typically found in the upper and middle esophagus, fibromuscular hypertrophy in the middle, and lower esophagus, and TBRs are primarily encountered in the lower third of the esophagus. 35 Roughly a quarter of cases are associated with esophageal atresia and tracheoesophageal fistula. 36 Although tight stenoses are symptomatic in infancy, most stenoses present with dysphagia and regurgitation in childhood when more solid food is ingested, see Table 43.2. The stenosis is best demonstrated by esophagography, which may reveal either an abrupt or tapered stricture. Dilatation of the esophagus proximal to the stenosis is commonly noted, see Fig. 43.10. Endoscopy may be of value by demonstrating normal mucosa in the stenotic region, helping to exclude an acquired cause for the stenosis, e.g., GERD. EUS with a high-frequency mini-probe can show hyperechoic lesions with acoustic shadowing, which indicates the presence of cartilaginous structures in patients whose stenoses result from TBRs. 37 Some patients improve after endoscopic guided bouginage or balloon dilation, although endoscopists should approach Fig 43.10 barium esophagograms in 2 patients with congenital esophageal stenosis. A. Barium esophagogram with a tapered narrowing in the distal esophagus and dilatation of the proximal esophagus. B. Barium esophagogram with an abrupt narrowing in the mid-esophagus, large arrows. The small arrow indicates the site of a previous repair for esophageal atresia. A and B, from Yuzui N, Kamada S, Kawahara H, ETAL. Usefulness of endoscopic ultrasonography in the diagnosis of congenital esophageal stenosis. J. Pediatra SURG 2002, 37:1744. AB 634 Part V. Esophageal dilation carefully in these patients because chest pain and mucosal tears commonly occur. Perforation rates of 10% to 44% following dilation have been reported. 38-40 Problematic stenoses require surgical resection of the involved segment. One novel surgical approach to this lesion is circular myectomy, a technique that involves stripping of the esophageal muscle layers containing the TBRs, with preservation of the mucosal layer. This has the advantage of avoiding many of the potential complications associated with primary repair and end-to-end esophageal anastomosis. 41 The stenotic segment in cases secondary to fibromuscular hypertrophy can be amenable to longitudinal myotomy. 42 Esophageal duplications. Congenital duplications of the esophagus occur in 1 in 8,000 live births and represent roughly 20% of alimentary tract duplications. 2,43 The pathogenesis of esophageal duplications is uncertain, although they may develop as a result of aberrant vacuolization during organogenesis. Duplications are composed of both epithelial lining and a well-developed smooth muscular layer, and maintain an attachment to the esophagus. Duplications can be either cystic, tubular, or diverticular in morphology. Cysts account for 80% of the duplications and are usually single fluid-filled structures that typically do not communicate with the esophagus. 2 Most duplication cysts occur in the lower esophagus and are located within the posterior mediastinum, although intra-abdominal esophageal duplication cysts have been reported. 44 The majority of esophageal duplication cysts are diagnosed in childhood, with 7% of cases presenting as symptomatic cysts in adulthood. 45 Some cysts are discovered while asymptomatic, manifesting as a mediastinal mass on a chest radiograph or a submucosal lesion on an esophagogram, Fig 43.11a. Others manifest with symptoms from compression of structures adjacent to the tracheobronchial tree, cough, stridor, tachypnea, cyanosis, wheezing, or chest pain, and of structures adjacent to the esophageal wall, dysphagia, chest pain, or regurgitation. See Table 43.2. 46 The diagnosis of an esophageal duplication cyst is supported by the demonstration of a cystic mass on CT, MRI, or EUS. See Fig 43.11b. 47 Duplication cysts appear as lesions that cause extrinsic compression of the true esophageal lumen with normal appearing mucosa. On EUS, duplication cysts can appear as homogeneous anechoic or hypoechoic masses with well-defined margins. 48 Peristalsis seen within a cyst is very specific, and is considered a diagnostic feature, of esophageal duplication cyst. 49 EUS guided FNA of duplication cysts for pathologic diagnosis is controversial due to the significant risk of procedure-related infection. 48 Surgical removal is the preferred treatment of choice for confirmed cases of both symptomatic and asymptomatic duplication cysts. 48 Rarely, large duplication cysts can manifest with acute life-threatening respiratory symptoms. In this circumstance, emergent decompression can be achieved by radiologic or endoscopically guided needle aspiration. The tubular esophageal duplication is far less common than its cystic counterpart, 20% of cases, and the diverticular type is rarely observed. The tubular type is usually located within the esophageal wall, parallels the true esophageal lumen, and, in contrast to duplication cysts, communicates with the true lumen at either or both ends of the tube. 46 Tubular duplications usually cause chest pain, dysphagia, or regurgitation in infancy, and the diagnosis is established by esophagography or endoscopy. ABAACS Fig 43.11 Imaging studies showing an esophageal duplication cyst. A. Barium esophagogram showing extrinsic compression of the wall of the esophagus. B. EUS image showing the distortion of the esophageal wall created by the hypoechoic cyst. C. And the cyst's relationship to other hypoechoic areas created by the aorta, A. Azygos vein, A. And spine, S. A. Courtesy David ODT, MD, Winston-Salem, NC, B. From Kimi MB, Vilman P. Endoscopic ultrasonography. In, Yamada T., Editor. Atlas of Gastroenterology. 3rd ed. Philadelphia, Lippincott Williams and Wilkins, 2003. p. 1044. Chapter 43 Anatomy, Histology, Embryology, and Developmental Anomalies of the Esophagus 635-43 Although some cases can be managed endoscopically, reconstructive surgery is indicated for most patients who are symptomatic. 46,50,51 Vascular anomalies. Intrathoracic vascular anomalies are present in 2% to 3% of the population. Only rarely do they produce symptoms of esophageal obstruction despite evident vascular compression on an esophagogram. In infancy, most intrathoracic vascular anomalies manifest as respiratory symptoms from compression of the tracheobronchial tree. Later in childhood or adulthood, however, these same abnormalities can produce dysphagia and regurgitation, owing to esophageal compression, see Table 43.2. Dysphagia lusoria is the term given for symptoms arising from vascular compression of the esophagus by an aberrant right subclavian artery, Fig 43.12.52. This condition results from defective development of the right-sided pharyngeal arch, which under normal circumstances transforms into the right subclavian artery. The right subclavian artery in dysphagia lusoria arises from the left side of the aortic arch and courses from the lower left to the upper right posterior to the esophagus. In 20% of cases the artery courses anterior to the esophagus. 53 It is estimated that arteria lusoria is present in 0.7% of the general population on the basis of autopsy studies. Typically the diagnosis is established by barium esophagogram, which shows the characteristic pencil-like indentation at the level of the 3rd and 4th thoracic vertebrae, see Fig 43.12b. 52 Confirmation is by CT, MRI, arteriography, or EUS, see Fig 43.12c. 53 Given the considerable frequency with which such lesions are asymptomatic, endoscopy or esophageal manometry may be desirable to exclude other causes of dysphagia. During endoscopy the right radial pulse may diminish or disappear from instrumental compression of the right subclavian artery. Esophageal manometry has demonstrated a pulsatile high-pressure zone at the location of the aberrant artery. 54 Symptoms usually respond to simple modification of the diet to meals of soft consistency and small size. When necessary, surgery relieves the obstruction by anastomosing the aberrant artery to the ascending aorta, see Fig 43.12a. 54 Esophageal rings. The distal esophagus may contain two rings, the A and B, Schatzky, ring, that demarcate anatomically the proximal and distal borders of the esophageal vestibule. The A, muscular, ring is located at the proximal border, see Fig 43.3. It is a broad, 4 to 5 mm, symmetrical band of hypertrophied muscle that constricts the tubular esophageal lumen at its junction with the vestibule. In this location the A-ring, which is covered by squamous epithelium, corresponds to the upper end of the LES. 55 The A-ring is rare, and because it varies in Fig 43.12 dysphagia lusoria. A. Anatomic configuration of an aberrant right subclavian artery, lusorian artery, as it courses behind the esophagus from the aortic arch toward the right shoulder. B. Barium esophagogram showing the characteristic diagonal indentation of the esophageal wall at the level of the 3rd and 4th thoracic vertebrae. C. CT with 3D reconstruction. A. From Janssen M., Bagan MG, Veen HF, ETAL dysphagia lusoria, clinical aspects, manometric findings, diagnosis, and therapy. AMJ Gastroenterol 2000, 95:1411, B. Courtesy David ODT, M.D., Winston-Salem, N.C., c. From 1. Hudzik B., Gassier M. Dysphagia lusoria. N. English J. Med 2016, 375, 4E4. CBA right common carotid artery esophagus left common carotid artery left subclavian artery Lusurian artery ascending aorta trachea descending aorta 636 part V esophagus caliber on esophagography depending on the degree of esophageal distension, it is generally asymptomatic. Occasionally an A-ring is found in association with dysphagia for solids and liquids, see Table 43.2. 0.55 Symptomatic A-rings can be treated by passage of a large caliber mercury-weighted esophageal dilator, injection of botulinum toxin, or by peroral endoscopic myotomy. 56,57 The B-ring, otherwise known as the mucosal or Schatzky ring, is very common, and found in 6% to 14% of subjects having a routine upper GI series. 58 A recent review of more than 10,000 upper endoscopies found a Schatzky ring in 4% of cases. 59 On barium study it is always found in association with a hiatal hernia and is recognized as a thin, 2 mm, membrane that constricts the esophageal lumen at the junction of the vestibule and gastric cardia, Fig 43.13a. The Schatzky ring has squamous epithelium on its upper surface and columnar epithelium on its lower surface and so demarcates the squamocolumnar junction. The ring itself is composed of only mucosa and submucosa, there is no muscularis propria. Schatzky rings can be congenital or acquired, and a relationship to GERD is likely, see Chapter 46.58 Most B rings are asymptomatic, yet when the diameter of the esophageal lumen is narrowed to 13 mm or less, rings commonly are the cause of intermittent dysphagia for solids or unheralded acute solid food impactions. See Table 43.2.60 It is usually not difficult to identify symptomatic rings on esophagography, see Fig 43.13a, or endoscopy, see Fig 43.13b, although attention should be paid to adequately distend the distal esophagus. 58 In some instances, the obstructing ring is best demonstrated radiographically by its ability to trap a swallowed marshmallow or a barium tablet, techniques that can also assist in determining the diameter of the ring. Asymptomatic B rings require no treatment, and those producing dysphagia are effectively treated by passage of either a single, large, symptomatic mercury-weighted dilator or a series of such dilators of progressively larger diameter. 61 Early studies reported that 32% of patients required repeat dilation after 1 year. 58 More recent studies report much lower redilation rates, 13%, perhaps due to the more routine use of both larger dilators and a course of post-dilation anti-reflux therapy. 62 In one randomized placebo-controlled study of 44 patients with symptomatic Schatzky rings, maintenance therapy with omeprazole resulted in a 40% reduction in the need for redilation after a mean follow-up of 35 months. 63 A recent observational study demonstrated that complete Schatzky ring excision using 4-quadrant jumbo cold biopsy forceps was safe and effective in preventing recurrence. 64 Symptomatic rings that are refractory to dilation have been successfully treated by endoscopic means using electrocautery incision. 65 A randomized controlled trial of standard Bougie dilation versus electrocautery incision for symptomatic Schatzky rings has demonstrated that the two therapies have comparable initial success rates but that endoscopic incision had a longer duration of symptom resolution. 66 Esophageal webs. Esophageal webs are developmental anomalies characterized by one or more thin horizontal membranes of stratified squamous epithelium within the upper cervical, esophagus and mid-esophagus. Unlike rings, these anomalies rarely encircle the lumen but instead protrude from the anterior wall, extending laterally but not to the posterior wall, Fig 43.14a and b. Webs are common in the cervical esophagus and are best demonstrated on an esophagogram with the lateral view. In up to 5% of cases they are identified in an asymptomatic state, but when they are symptomatic they cause dysphagia for solids, see Table 43.2.67 Webs are fragile membranes and so respond well to esophageal bouginage with mercury-weighted dilators. AB Fig 43.13 Imaging studies showing an esophageal B. Schatzky ring. A. Barium esophagogram showing the ring of mucosa localized to the squamocolumnar junction. Below the B ring is a hiatal hernia. The hernia is visualized as a small sac between the B ring above and the diaphragm below. B. Endoscopic view of the ring. A. Courtesy David ODT, MD, and Winston-Salem, NC. B. Courtesy John D. Long, MD, and Winston-Salem, NC. Chapter 43 Anatomy, Histology, Embryology, and Developmental Anomalies of the Esophagus 637-43 as discussed in Chapter 37, an association in adults of cervical esophageal webs, dysphagia, and iron deficiency anemia has been described as the Plummer-Vinson or Patterson-Kelly syndrome. 67 The syndrome, although uncommon, occurs primarily in women. There may be an association between Plummer-Vinson syndrome and celiac disease. 68 The syndrome identifies a group of patients at increased risk for squamous carcinoma of the pharynx and esophagus. 67 Correction of iron deficiency in Plummer-Vinson syndrome may result in resolution of the associated dysphagia as well as disappearance of the web. 67 Heterotopic gastric mucosa, inlet patch. The inlet patch refers to the appearance on endoscopy of a small, 0.5 to 2 cm, distinctive, velvety, red island of heterotopic gastric mucosa amid a lighter pink squamous mucosa, generally localized immediately below the UES, Fig 43.15a. When sought, an inlet patch is found in up to 10% of endoscopies, and biopsy specimens reveal gastric fundic or antral type mucosa, see Fig 43.15b. 69,70 The fundic type mucosa contains chief and parietal cells and, thus, in some specimens retains the capacity for acid secretion. 71 Similar to gastric mucosa in the stomach, the inlet patch may be infected with HP. 72 However, inlet patches are usually asymptomatic and unassociated with disease and thus require no treatment. A possible association with globus pharyngeus was suggested in a study in which this symptom was improved after ablation of inlet patches using argon plasma coagulation. 73 In rare instances, an inlet patch is found in association with an esophageal web or stricture. 74 Or ulcer, the latter resulting in bleeding or perforation. 69 Adenocarcinoma arising in an inlet patch is a rare complication, although there is a statistically significant association between inlet patches and proximal esophageal adenocarcinomas. 69,75 The necessity of surveillance endoscopy is controversial and a formal consensus has not been reached.